This is our diversity problem-solving project on the underrepresentation of racial minorities and women in medical research.
Hi, everyone. Today I'll be introducing you to the issue of diversity in healthcare research. One of the biggest problems in healthcare today is that clinical trials have historically included mostly white male participants. Because of this, the result of many medical studies don't always accurately represent women or people of different racial and ethnic backgrounds. This issue affects a wide range of people. It impacts patients who really rely on safe and effective treatments, healthcare providers who use research to make medical decisions. Research conducts clinical trials, pharmaceutical companies developing new medications, and government agencies like the FDA and the NIH that oversee medical research. This topic is especially important today because healthcare is becoming more personalized and our population is becoming increasingly diverse. Medical research should have reflect the people it's meant to help. By improving diversity in clinical trials, research can develop treatments that are safer, more effective, and better suit for everyone, not just one group. Okay, so to understand why this is an issue, it's important to look back on history. So, for many years, clinical trials have primarily included white men, while women and racial minorities were often excluded. As a result, researchers have limited information about diseases and treatments affecting different populations. Since people can respond differently to medications based on factors like sex, genetics, and ethnicity, this lack of representation creates important gaps in medical knowledge. In recent years, organizations like the FDA and the NIH have recognized this problem and have taken steps to improve diversity in clinical research. Their goal is to make medical research more accurate, ethical, and represent the population as a whole. So there are several statistics that show how significant this issue is. According to Johns Hopkins Medicine, about 94% of clinical trial participants have historically been white, making it difficult to apply research findings to entire populations. To address this, the FDA encourages clinical studies to sponsors in 2025 to create diverse action plans that increase participation based on factors like race, gender, and age. Studies have also found that more diverse clinical trials produce better medical knowledge and improve patient care for everyone. Different groups have roles in solving this issue. That these include the NIH and the FDA, healthcare providers, medical research, hospitals, patients, and pharmaceutical companies. Looking at this timeline, one major milestone was the NIH, sorry, re re sorry guys, I'm like dyslexic. So, uh, Rehabilitation Act of 1993, which requires women and minorities to be included in uh, federally funded clinical research. In 2018, the NIH expanded these efforts through its Women and Minorities in Clinical Research programs. And most recently, in 2025, the FDA encourages the Diversity Action Plan to improve participations from underrepresentation group. So these efforts show that while progress has been made increasingly in clinical research is still an ongoing priority.
So, to make sense of this problem, we're applying critical race theory. CRT argues that racism is more than individual prejudice. It can be built directly into institutions, laws, and policies. That's a different claim than saying individual researchers are biased. It's saying that the system itself can produce unequal outcomes even without anyone intending it. A core idea within CRT is that race is a social construction, not a biological determinant of health outcomes. That matters here because it means difference in health outcomes across racial groups usually reflect social conditions and unequal access, not some inherent biological difference. CRT also explains that racism can operate through cultural norms, institutional rules, and regulations, not just through individual bias. In other words, a policy can produce a racially unequal outcome without a single person in the room being personally prejudiced. Altogether, that gives us a framework for understanding why racial inequality can persist even in systems that are formally equal on paper, which is exactly the situation we see in clinical research. Applying that framework directly to our issue, medical research has historically failed to include enough women and racial minorities, especially women of color. This isn't a hidden problem. Even NIH policy itself acknowledges that research needs to determine whether treatments affect different groups differently. That's essentially an admission that the current evidence base has gaps. Two concepts help explain how this happens. The first is institutional power. Medical institutions are the ones deciding who gets recruited into studies and how the findings get explained afterward. That's a lot of control concentrated in a small number of decision makers. The second is trust. This is where communication becomes central to the problem. Underrepresentation often gets framed as a matter of certain communities simply not trusting medical institutions. But our research suggests it's often the reverse. Underrepresentation reflects failure in outreach and communication from institutions, not unwillingness from communities. So the communication breakdown isn't just a side effect of the problem, it's part of what's producing it. Put together, underrepresentation in medical research isn't a personal failure on the part of patients or researchers. It's a pattern shaped by institutional power and broken communication and trust. It's worth acknowledging the other side of this argument, since not everyone agrees mandatory diversity requirements are the right approach. Some researchers argue that these requirements add real cost, time, and complexity to studies that are often already underfunded. Recruiting a more diverse participant pool can mean more outreach, more translation services, and more trial sites. And that's a legitimate operational concern. There's also more flexibility built into the system than people might expect. FDA guidance actually allows sponsors to request waivers from diversity action plan requirements in certain cases, which shows that even the agency pushing for these requirements recognizes that a one-size-fits-all approach doesn't always work. That leads to a fair counterpoint. These requirements should stay scientifically appropriate rather than becoming a simple checklist. Diversity for its own sake isn't the goal. The goal is research that actually produces accurate, generalizable results. Our response to that is that like flexibility and accountability aren't mutually exclusive. Allowing exceptions in specific justified cases doesn't mean the overall goal should be abandoned. It just means that the system needs a real process for these exceptions, rather than using them as a way to avoid accountability altogether.
Now that we've looked at the problem and the theory behind it, let's talk about what can actually be done. Our first two proposals are both about structure, what the law already requires, and where the funding support has gone. In 2022, Congress passed FDORA, which already makes diversity action plans legally binding for federally funded clinical trials. Sponsors are supposed to set enrollment targets by race, ethnicity, gender, and age, and face funding consequences or added review if they fall short. So this isn't a case of the law not existing. The issue is enforcement. In January 2025, the FDA actually pulled this guidance from its website, and it was only restored later under a court order. Our proposal here is simple: enforce the law that's already on the books. Now, funding. The NIH has run a research supplements to promote diversity programs using PA-23-189 to fund trainees on existing grants. That program's funding notices were withdrawn as of January 2025. Our proposal is to reinstate it and expand it, trying funding specifically to measurable progress and diverse recruitment. A program built to fix underrepresentation getting paused is a clear example of what we mean when institutional power can roll back progress. even after it's already been formally established. Our next two proposals are about what happens after the funding exists, who does the work, and whether the results actually get reported. First, community healthcare workers and patient navigators. In one study, patient navigation raised trial completion from 37.5% to 74.5%. These are the people who address the practical barriers, transportation, language, and trust that keep people from participating in the first place. Our proposal is that the reinstated funding from the last slide should go directly towards hiring and paying these workers, not just training programs. Second is transparency. Only 43% of over 20,000 US clinical trials even reported race or ethnicity data. So even when a trial is diverse, we often can't tell because it isn't published. Our proposal is to require journals to mandate demographic reporting as a condition of publication. Together, these four pieces, enforcement, funding, on-the-ground support, and transparency, target four different stages where the problem has been allowed to continue. That's exactly what critical race theory points to. This isn't one bad actor or one oversight. It's a pattern built into the system, which means the fix has to be systemic too. Underrepresentation of women and racial minorities in medical research is a systemic pattern, not an oversight. Critical race theory helps explain it through who gets recruited, who has access to care, and whose bodies get treated as the default in research design. What's striking is how current the problem is. The federal requirements exist, but enforcement was paused in 2025. A dedicated NIH funding program was withdrawn that same year. These aren't old historical examples, they're happening right now. And they show how institutional power can undo progress even after it's been formally established. Our proposed fixes go after that directly. Enforce the law that already exists, restore and expand funding, invest in community healthcare workers and navigators, and require transparency in publication. This matters because medical research shapes healthcare decisions for millions of people. Fair representation means more accurate treatments for everyone, and it means rebuilding trust between marginalized communities and the institutions that are supposed to serve them. And these are our sources.